Go for it.
All right. Well, good to see you all. Happy Valentine's Day again. I'm going to move my chat just so that I can see a few more things on my screen. So Shan, just help me if anything comes up. But afternoon, happy Valentine's Day, happy February. My name is Jason Rosenfeld. I'm an assistant professor in the Department of Medicine and director of global health education at UT Health San Antonio. I'm also the director of the South Texas Community Health Worker Workforce Preparedness Collaborative, which I'll talk about here in just a moment. But welcome to the third of our webinar series focused on employers within public health, healthcare, and social service agencies with the goal of really kind of increasing awareness about community health workers, the work that they do, their impact, financing models, etc. This is, as I mentioned, the third. The focus today will really be on impact. So we want to share the state of the current evidence around community health workers, and then bring some stories from the field with practitioners and experts who have worked with CHWs, who have trained them, who have been in this space for a long time. And then we'd also love to hear from you, really to kind of help continue to make the case for why community health workers are essential parts of our public health, healthcare, and social service systems. So again, we're here in our welcome stage. We really encourage you at this time to just insert into the chat who you are, where you're coming from, what your role is, whether you're a CHW, CHW ally, employer, or otherwise. We'd love to kind of know who's joining us today. We'll then jump into a couple of things. I am going to give the briefest of overviews of the updates on Medicaid laws supporting community health worker reimbursement here in the state of Texas. And I want to thank many colleagues for sharing some information this week to help me bring this piece together. And then I'd welcome anybody with more current information about the new laws to jump in as well. Then I'm going to hand it over to my colleague, Shan Martin, who's going to talk about the kind of overview of impact and evidence before we jump into our two panelists, Jake McClellan and Dr. Teresa Wagner, who we'll introduce in just a little bit. But that's our agenda for today. See if I can advance these slides. And so before we jump in, I just want to again level set on who we are and who's bringing this webinar to you today. This is on behalf of the South Texas Workforce Preparedness Collaborative, of which I have the honor and privilege of directing. The goal of this program with HRSA funding, Health Resource Service Administration, is to expand the public health workforce, increase the number of trained and certified community health workers across the country, upskill existing community health workers by providing additional continuing education training and skill building to help you do the job that you're already doing as a CHW even better. We want to increase preparedness to work in public health spaces by designing public health oriented curricula, and then also helping to expand the workforce and opportunities for employment across the state, and then really at the end of the day, advance health equity issues by really expanding this workforce and building your capacity to respond to the needs of your communities. I'm not going to read our overall mission and vision here, but at the end of the day, we serve 38 counties across South Texas, from Bexar County, which is where I call home in San Antonio, all the way out to the border in Laredo and down to Brownsville. And again, our goal is to increase the diversity of the workforce to address the needs of the communities, both urban and rural. Our partners are many, and we want to call them out and thank you all for being partners in this. Northwest Vista College and the South Texas Area Health Education Centers, which are our core training partners, and then helping us develop our curricula and our experiential learning opportunities. You can see all of our partners listed there on the right side of this slide. There's many, many more who are part of this, including colleagues at University of North Texas Health Science Center, which Dr. Wagner is part of, who are helping us with evaluation and other pieces. The area that we're targeting are these 38 counties here highlighted on the map. Our priorities are bringing in the youth into this workforce, focusing on addressing gaps in rural counties where CHWs can work, but maybe haven't in the past, and then trying to think about how do we expand and sustain the Spanish-speaking community health worker workforce in South Texas by providing continuing education opportunities in both English and Spanish. Again, in terms of our programs, we provide CHW certification. We provide professional support services. We have a complimentary monthly professional development series that we offer for community health workers. Some carry CEUs, some do not. So keep on the lookout for those opportunities. I think our next one will be next month, correct, Shan? Or is it this month? On CVs and preparing for employment. Do you want
Yeah,
to
just
say?
a plug for tomorrow. We actually have one tomorrow on filing a 1099 as a CHW, as many community health workers are in contracted work. And then it's the third Thursday of every month at noon. So you can reach out to get on that list.
Thank you so much. We also help with offering experiential learning opportunities and internships as part of your CHW training. And then finally, a new piece, which I know Jake is going to talk a little bit about today, is registered apprenticeship. So on-the-job training components for community health workers within current employment opportunities. Very quickly, in terms of our progress, we've been at this as a collaborative for a year and a half, but I want to be clear that our training partners have been doing this for decades. But so over the last year and a half, we've trained over 120 community health workers in the counties that you can see highlighted here on the map. Still some opportunities in some of our rural counties in South Texas to expand that workforce. 90% of our trainees have completed some form of an internship or experiential learning opportunity, which we're really proud of. And then finally, we'll be launching our first apprenticeship trainings here in 2024. So thanks for those overviews. I want to just quickly touch on some of these updates on CHWs and Medicaid. So my first disclaimer is that this is not my, I shouldn't say it's not my area of expertise, but this is a constantly evolving and moving piece. But what I want to raise everyone's awareness about is that there's two main state legislations that have changed as of the 88th legislature. The first is HB 113, which has changed the way that community health workers can be reimbursed under Medicaid managed care. And so basically, CHWs have been recategorized as quality improvement and not as an administrative cost, which simply means that when we look at the ratio of how people pay for things, CHWs are on the top end of this quality improvement and not on the bottom end of it in terms of overhead expenses, which means it makes it easier and it adds to the value of care that's offered, making it potentially easier to now pay for community health workers under Medicaid managed care. Shane, did you want to jump in? Did you unmute her? Okay, just making sure.
No, go ahead.
Okay, so that's number one, still figuring out what all of that means, but I think it's an overall positive in terms of how we can pay for this workforce within Medicaid programs. The second, oh, that was my arrow to show that it's moved from the bottom to the top of that ratio. The second piece is looking at HB 1575 on maternal health and Medicaid. So there's a couple of components to this. And again, this is a constantly moving target because this legislation is just going into effect last month. So we're expanding Medicaid coverage for up to 12 months for pregnant mothers or those that have just recently delivered. Doulas and community health workers are now eligible to be reimbursed under Case Management for Children and Pregnant Women, the CPW program. And then there's going to be an enhanced screening for what they call non-medical drivers of health, also known as the social determinants of health, upon enrollment in Medicaid for pregnant and expecting mothers. So those are the kind of big pieces writ large. Where are we at right now? So CPW has to update the provider list, meaning that CHWs and doulas need to be listed as providers to be able to get reimbursed under this program. That is ongoing. They must be state certified, right? So this leads into the program that we're feeding in, right? So if you want to get reimbursed, if you have a plan or a program, you have to be a state certified community health worker to be able to get reimbursed. The fee schedule is currently under negotiation, and there's going to be some meetings coming up. No dates have been provided as of yet, but be on the lookout for that information where you can provide public comments. And then finally, the timeline that we know of at this point. So screening requirements will be submitted and finalized by fall of 2024. Provider enrollment requirements, which is the CHWs and doulas who can be reimbursed under this program, by the summer. Implementation of new providers by the fall. So basically what their timeline is they want to begin implementing this program in fall of 2024, providing education in the summer and developing the claims and billing systems by fall. That is what I know. This is what's been shared with me. I'd love to hear if anybody has any additional comments or thoughts on these two pieces that maybe I have missed or have gotten incorrect. I'm going to leave it for just a moment to see if there's anything people want to add. And if not, then I'm going to move us right along. Because I know there's lots of experts, and I'm not going to call on anybody specifically, but you know who you are. All right. Well, what we'll do then is we'll hold the questions and comments on that as well as the rest of this conversation for later. And now I'd like to hand it over to my good friend and colleague Shan Martin to give us an overview of the community health worker evidence to date.
Thanks, Jason. That really keys it up for me with like the recent focus of Texas funding CHWs to address social determinants of health. And that's where a lot of the past evidence for CHW lies. And so before I hand it over to our speakers, I just wanted to give you about a 75-year history of CHW evidence and kind of where we are today. So CHWs, you probably know, have worked around the world for a very long time, more than the 70 years that is here, but formally in the US or informally through different rural health systems, the evidence of CHWs has been documented for about the last 70 or over the last 70 years. But it wasn't until 2007 that for one of the first times in history, there was a report that documented the evidence from the 1950s to the 1980s. But even despite that evidence, several attempts to increase state and federal funding in the 1990s and early 2000s failed. Some of the criticisms were the studies were of low quality or low rigor, and it was difficult to compare results across interventions. However, 2010 onward has really ushered in a period of growth for CHW evidence. The Affordable Care Act, it ushered in value-based payments, and this led to the expansion of CHW programs. It was only in 2011 that community health worker was made an official employment designation by the Bureau of Labor Statistics. But this is another mechanism that now we have a workforce that we can study. Growing interest in addressing social determinants of health, as growing evidence showed that addressing social determinants of health impacts outcomes, health systems began to incorporate CHWs as effective partners for addressing those social determinants of health. And then finally, what we're all most recently familiar with, through COVID-19, there were two big funding mechanisms for CHWs. One was the CARES Act, and then also the American Rescue Plan. And there was funding set aside specifically for CHWs because they're recognized as frontline health workers and being able to reach the most marginalized populations. So we went from a period of low evidence, although there was the motivation to get CHWs formally integrated into the health system, to a period of high evidence. Now through randomized controlled trials and stronger quasi-experimental methods, we have studies that demonstrate CHW interventions can lead to improvements across what is known as the triple aim of healthcare: improved population health, improved patient experience of care, and reduced costs. And altogether, this holds promise for advancing health equity. So right here, I kind of have from a summary of the evidence from the last 20 years in those three buckets. So in relation to improvements to population health, this is kind of where the evidence is strongest. And in many CHW interventions are disease specific. And so the intervention is, or the evidence is able to show that there have been, that CHWs help improve health behaviors, and which leads to improved outcomes. And it's mostly around chronic diseases, such as diabetes, hypertension, HIV, and pediatric asthma. These are the health areas where the evidence is strongest. There's also been randomized controlled trials that show CHWs help improve self-efficacy, depressive symptoms, and caregiver quality of life among the populations they're working on. And newly, there's emerging evidence on improved pregnancy and perinatal outcomes. This is, I think, an exciting area to build the evidence, especially with across the U.S. increased focus on expanding Medicaid for postpartum women. And right here in Texas, we're seeing funding CHW work for reproductive care. Moving on to patient experience of care, there's been several symptomatic reviews on different types of cancer screenings. So populations that are usually that face barriers to the healthcare system have lower screening rates and therefore worse cancer rate outcomes. And so this is an area of improving of how CHWs improve the patient experience of care. There's also RCTs on increased access to both primary care, which can prevent catastrophic health events, but also follow-up care. So patients report improved communication of hospital discharge instructions and follow up on risk factors for diseases that can then be followed on within an ambulatory care setting. And then there's the reduced cost of care. The concept is that if we're reducing more expensive care and hospital healthcare utilization to begin with, by the CHWs addressing prevention and upstream factors of health, then we're reducing healthcare costs. So the evidence here is there's randomized controlled trials on that show reduction in hospital days, lower mean stays, lower rates of emergency department utilization, reduced hospitalizations and unscheduled healthcare. Oh, you guys are seeing mine.
I didn't want to interrupt you.
Sorry. I just had the thought to check it. And then also some cost savings among adults with chronic health conditions. So a lot of the funded programs nationally are Medicaid supported. So there's evidence for returns of investment among Medicaid payers. That what's been showed recently is for every dollar invested, up to $2.50 has been saved. So I kind of summarized that the focus on the reduced cost of care is because of lower utilization. I would say the summary of the improvements to population health and how we're able to improve population health by partnering with CHWs is CHWs often provide culturally relevant and non-judgmental support regarding health behaviors. Studies demonstrate that CHWs are able to increase patient knowledge, appointment keeping, and medication adherence. In terms of why we're seeing improvements to self-perceived quality of care, the experience, evidence shows that it's the CHW's lived experience and trust-building qualities that make them equipped to improve their population's access to care and increase uptake of preventive services, which I mentioned that it's in communities that have historically been harmed by the health system or have systematic barriers to accessing care. They're also they also work with communities who experience compared to white patients, poor treatment by health providers, poor quality of care. So all of this together builds to this opportunity to advance health equity. CHWs are acting as that liaison between marginalized community and the healthcare system. They work with groups who are disproportionately affected by the leading causes of death and illness. And so, but this is also an area that it's an important area for research. The evidence is still emerging. So I hope that if you are in a position to contribute to the evidence on how CHWs being integrated to the health system can build the evidence base for health equity, then please do that. All right, before I get into our stories from the field, I do want to say that we first want to hear from CHWs and the impact that they perceive that they have had on their patients, their clients. And so if you were on a few months ago, we heard about how CHWs have been at the UT Health San Antonio Department of Family and Community Medicine for about 2 decades now. And so I just want to play a video. And if I'm going to play it in a second, and if you can't hear me, just someone raise their hand.
I believe I impact my patients. As a CHW, I believe I impact my patients' life by visiting their home and meeting their family. I support my patient by going to their visits with their PCP. I make an impact on patients by listening to them with care, respect, and compassion. As a community,
Sounds like we lost it, Shan.
As a CHW promotor, I impact my patients and I support my patients by listening to their stories without judgment and providing feedback and advice.
Como promotora, yo desarrollo confianza con mis pacientes, hago mi trabajo de corazón y trato de ayudarles a resolver sus problemas. As a promotora CHW, I fight the fight together with my patients to address the enormous socioeconomic and healthcare barriers that they face.
All right. And before I move on, are there any CHWs on that would like to speak up or add to that? No?
Hi, this is Rose Williams. Can you hear me?
Let's go with Rose first.
Hi, this is Rose Williams. I'm over at University Health. Was part of the Institute for Trauma-Informed Care, and I'm working over at the hospital with trauma survivors, the program, but also doing community work. And so, you know, CHWs, I've been a CHW for 16 years, and we're seeing some movement with University Health, which I'm very grateful for, as far as our CHWs. And so, working as a frontline worker in the community, we will work with Big Mama Safe House, a nonprofit organization. And so the frontline worker is the CHW, even during COVID, right? And they're the ones that get to the heart of the people. They meet them where they're at. So I'm really excited to come on. I get your invitations all the time. So thank you for that. I'm grateful to be on this session with such great champions that serve San Antonio and Bexar County. Thank you.
Thanks, Ms. Williams. I think there was another voice that I heard.
Oh, yes, ma'am. That was me. My name is Aisha James. I'm a CHW here in Houston. I covered the coastal region. Previously, I worked for Texas AHEC East. They were partnered with UTMB. I obtained this position through COVID. We did a 2-year health disparities project where we were to go in the underserved communities and cater to the underserved and be that bridge for them to health access. Once that grant ended, it ended in November. I love the passion that that came with it from doing that job, and I created my own nonprofit foundation. It led me to do that. And so with that, I still continue to serve the areas. And one thing that I do for the community is I cater. My favorite is catering to the seniors. I know that for the seniors, they're on a fixed income, so they can't afford the basic necessities of life. So what I do is the health events that I've been invited to throughout the coastal region pertaining to the seniors, I go to Dollar Tree and I purchase laundry detergent, even the bounce sheets. I go and I grab bundles of everything and I have them just spin the wheel with no cost, just spin the wheel just to see what they win. And it's a pleasure to be here with others that are willing to serve their communities.
Thanks, Ms. James. I think, Rose and you both brought out what I was trying to explain about addressing non-medical drivers of health, social determinants of health. And so thank you for sharing your experience. Because we love Ludi, I'm going to let you speak and then we'll move on.
Yes, so I'm very proud to be a community health worker and instructor, but especially I had wanted to work within my community setting, and have the opportunity now where we have a satellite office on the west side of San Antonio, which is where I live. And we're providing, through collaboration with the university hospital, we're providing educational classes for community members. And yeah, we have residents that come in and give presentations on subjects of health, or different types of presentations for the community as the community request, and that has been very fruitful in the learning of the community, because I've always said that when we know better, we do better, and that's what the community that keeps coming back and adding more to their knowledge about how to take care of themselves and advocate for themselves.
Thank you. And that's what's really come out strongly in the literature, is it's the ability of CHWs to impart health knowledge on their patients, on the members of the community they're serving. And so that communities who maybe have started with a lower baseline of health knowledge are able to live healthier lives with that knowledge and make lifelong changes. So thank you for sharing. And I hope that more will ask their questions to the panelists, or even feel that they can respond during the Q&A at the end. So as we always do in these quarterly webinars, we have speakers who are experts in their organization representing healthcare, social services, or community-based organization. And I'm very excited that today we have two speakers, Dr. Teresa Wagner. She's an associate professor at the University of North Texas Health Science Center at Fort Worth. And then Mr. Jake McKellen. He is a consultant with the Healthcare Career Advancement Program. We are going to start with Jake. And so over to you, Jake.
Thank you so much. And do I have the ability to share my screen?
You should.
Okay. Give me 1 second then.
Perfect.
Awesome. So thank you so much again, Shan. I appreciate it. Thanks for inviting me. As Shan mentioned, my name is Jake McClelland. I am with the Healthcare Career Advancement Program, or HCAP. I am a subject matter expert consultant when it comes to healthcare registered apprenticeships, which is our primary area of focus. And just as a heads up, I'm actually kind of pinch hitting for my colleague, Madeline, who had an unexpected scheduling conflict come up. So she is more of our resident community health worker expert, but I am working just through the registered apprenticeship model with partners in about 6 states to do the community health worker, and especially explore that registered apprenticeship model, as I mentioned. So thank you again for allowing me the time. I'm looking forward to talking a little bit about that, and just also sharing some stories about the impact that community health workers have had. So just a quick overview. Again, I'm with HCAP. We are a national labor management organization that promotes really any kind of innovation and quality in the field of healthcare education. Even though we are a national labor management organization, we actually work with both union and non-union employers. So if you are a non-union shop, don't worry about that. We just, we are affiliated with a union, but we serve all kinds of different employer partners. We are currently what's called an apprenticeship intermediary through the U.S. Department of Labor's National Office of Apprenticeship. And so what that means is that we are able to work with and provide no-cost assistance to any employer, any educator, educational institution, community-based organization, any stakeholder that's interested in exploring the registered apprenticeship model, not only in healthcare, but we actually now, over the last couple of years, have added behavioral health, as well as what we call the care economy. So a lot of sort of like, long-term care facilities and things like that. But also we do like early education. We have other consultants that work on that. So any of those industries, employers that are interested in kind of exploring the apprenticeship model, we are able to work with. And then we are also happy to announce that in 2023, we were actually named an apprenticeship ambassador by the DOL for the work that we do in this area. So as I mentioned, Shan did a great job of kind of giving the background and history of CHWs and sort of the basic overview. I did want to share, though, just a couple of examples that I know Madeline specifically has some interaction with of a few programs and just the economic impact that they are having in their communities. The first, of course, is going to be the Sanford Community Health Paramedic Program. This one is in North Dakota, and they actually reported saving about $1.1 million over a 9-month period with their CHW program. It's one person, which makes it even more amazing. And really their focus was kind of looking at those frequent hospital or ER visitors, some of the repeat visitors. And really what they did is they just created a system where that person was flagged in their EHR after they had, been in a certain number of times, and then they were referred to work with a community health worker. And as you all know, that individual just kind of provided them with some additional resources, helped them learn about alternatives, like you don't have to come into the ER every time you're feeling a little sniffle or, whatever the case may be. And so that was their success. There's also Molina Healthcare in New Mexico. This program, again, reported saving about $2 million. Then what they did is they really just provided access to resources for those who, had those high social determinants of health. They may have had some complex medical needs or other social barriers, and really just provided them with resources to the community that they otherwise weren't aware of or hadn't been accessing in the past. And then finally, Arkansas CHW program. This one reported having a 3-to-1 return on investment for Medicare expenses. Again, very simply, just by referring seniors to the various community-based services that they weren't accessing, just looking at it as an alternative to nursing homes. So I think, as you all know, I'm probably preaching to the choir, but the great thing about the community health worker role and the economic impact is really just kind of how these very simple interventions a lot of times end up saving quite a bit of money. And so making the case that these are roles that every organization should have. One other quick highlight, a success story. This is one that I know Madeline who lives in Montana, is actually very intimately familiar with. This is the FUSE program. They actually focused on the homeless population and supporting homeless patients. They had 2 full-time community health workers for their 45 clients, and they reported over a 6-month period of time, as you can see there, a 37% decrease in the mobile crisis unit usage, 56% decrease in the ambulance utilization, 57% decrease in ER visits, 24% decrease in urgent care visits, which they equated to basically about $158,400 in savings over that time period. The other thing that was really cool about this particular program is that it not only affected the health system, but also they were working very closely with their local criminal justice system. And so they saw a 66% reduction in calls to the Helena Police Department and an 89% decrease in the number of days incarcerated for those individuals, which the county detention center actually estimated that was an additional 50 savings just on their end. So now we get to apprenticeship. This is really the part that I'm more familiar with. And so as I mentioned, HCAP, we're a national intermediary for healthcare apprenticeships. We work with dozens, if not hundreds of partners across pretty much every state at this point, I think, working with them to help them start their own apprenticeship programs and also just providing information. So some of you may be familiar with the apprenticeship system, but probably not unless you or somebody has been through like a construction industry program, electricians, carpenters, plumbers, masons, etc. They've really been using the registered apprenticeship model for literally 100 years, and they have had a lot of success with it. As you'll see here in a minute, there's quite a few benefits, not only for the individual, which is pretty evident, but also for the employer as well. But there is a lot of confusion still when it comes to healthcare and some of these other industries. Probably the last 10 years or so, we've seen a big push in the workforce development world, especially from the Federal Department of Labor, to expand the apprenticeship model to these other sectors. And really, it's just that win-win situation that really is driving it. But if you're not familiar with apprenticeship, really, it's quite simply just a combination of paid on-the-job training with some kind of classroom training element. In a registered apprenticeship program, there are certain minimum requirements that you do have to reach as well. So it's typically about 144 classroom hours, along with roughly about 2,000 or 1 year of training on the job. That, there's a lot of kind of, without getting too far into the weeds, ways that you can bring that number down to a certain degree by utilizing a competency-based program versus a time-based. But typically it runs about a year in length and has some kind of classroom component to it that's about 144 hours. The kind of the two hallmarks of the apprenticeship programs or structure, of course, is going to be that earn and learn model. If you've heard that term before, again, this allows the apprentice to receive a paycheck while they're in school, while they're completing training. I would say 90+% of apprenticeship programs are also, the education costs are paid for on behalf of the apprentice. So not only are they getting a paycheck, but they're actually getting their education covered at no cost to them. And they're able to basically do it at the same time. So it very much streamlines the process. If you think of kind of your more traditional education models where you may have to go sit in a classroom for 6 months, 2 years, 4 years, depending on the program you're in. And then at the very end, you might get some actual hands-on learning through a clinical internship or through an externship or whatever you want to call it. This really, just like I said, streamlines the whole process. People are hired from day one. They move into the apprentice role. They receive their paid on-the-job training, and they start their education, and it's all kind of combined in this really great model. The other thing that we like to highlight about apprenticeship is that it's a very customized and flexible model. So like I said, there's those minimum requirements that are involved, but outside of that, the structure, how it's set up, when people do the training versus the education can be very much adapted and made to fit for any kind of business. So that's another thing that we hear a lot about is like, hey, we're not able to train people because we can't do it this way. Apprenticeship model, as long as it has that paid OJT and that classroom component, there's almost no occupation or program that can't be made to fit into the model. So the registered apprenticeship roles, there's 3 primary ones. The first is the sponsor. So this is just the organization that kind of is the day-to-day management. They oversee the program. They work with the employer partners if they are not themselves the employer, because the employer can also be the sponsor. They help register folks in the system. They provide that support. It's a lot of the administrative duties that, entering information to the database, National Apprenticeship Database, and things like that, where it's really, like I said, the organization or the entity that's running the program. The second component, of course, is going to be the education partner. Very much a lot of flexibility in this as well, as I mentioned. So we have some registered apprenticeship programs that we work with that will be partnered with their community college, some other kind of local post-secondary institution, but really you don't have to work with a community college if they don't have a program or if it's just not a good fit for what you're looking for. There's lots of online models that are used for the education. Some employers elect to do the training in-house. For community health workers specifically, I know we see a lot of, there's usually like some kind of basic training that's involved where they are counting that towards the education hours and then combining it with either like CPR or talking about more, setting specific things like whether they're a community health center or some other kind of community-based organization. So adding that into it to get to that 144 hours. And then last but not least, of course, is going to be the employer partner. So as I mentioned, the apprenticeship is a paid role. So there does have to be an employer involved that's willing to hire that individual and provide that on-the-job training while they complete their education. And as I mentioned before, so these 3 roles can be done by a single entity. If the employer wants to do their own education in-house and wants to be the sponsor, it could be 2 partners, like an education is also the sponsor, and they're working with employers, or you could have actually 3 different organizations performing all 3 roles. It doesn't matter. So why apprenticeship? I think, most people, when they think of it, again, it's going to be that earn and learn component. It's going to open up opportunities for individuals who may not otherwise be able to afford more traditional college or education programs. Even if, they could afford the cost of tuition, a lot of times Folks in those situations cannot, drop out of the workforce while they go back to school. If their employer's not flexible and doesn't let them like adjust their schedule, it becomes impossible, or they, the employer may not allow them to be in class at a certain time, so they have to end up cutting back their hours. So there's just opens up opportunities for a lot of people that may not otherwise be able to access post-secondary education. Because of that, and because at least most of the community health worker programs that I'm aware of already require some kind of combination of OJT and classroom training, it's actually a great fit for this occupation, I believe. I think Shan mentioned, the whole purpose of the community health workers is to take sort of these underrepresented and underserved populations, train up people that are representative of those communities and those populations, and move them, into these community health worker roles. Apprenticeship is very much similar to that, regardless of the occupation. So again, taking folks that speak the language, allowing them to kind of train up, get paid while they go to school, and then at the end, they're community health workers and able to go and assist others, which is great. And then last but not least, I think there's also, with that push in the workforce development world to kind of expand the model, we've seen a lot of grant funding that is now associated with registered apprenticeship programs, not only through the HRSA Community Health Worker Training Grant that Jason talked about at the beginning, but the Department of Labor is constantly putting out registered apprenticeship grants for what we call non-traditional sectors, which is basically anything but construction. And then local and state workforce agencies also, we've seen, not only do they have reoccurring funding that they can use towards this, but they are actually trying to promote this because it is a guaranteed job for the individual. So not only is it win-win for the employer and the individual, but the funder, a lot of times it's a win-win because they are getting the outcomes that they are looking for. So finally, real quick, NYCHA, the National Center for Healthcare Apprenticeships, is under the umbrella of HCAP. It is actually a program that we have gone to Department of Labor, and we have registered about 15 to 20 different more common occupations, including community health worker. So we serve as a sponsor on behalf of employer partners and other stakeholders across the country. Basically what that does is it allows employers to sort of participate or benefit from the registered apprenticeship model without having to take that burden on themselves of knowing all the paperwork, employing an individual to do like a lot of the administrative duties. We also like to say it's a kind of a try before you buy model. So if you're not quite sure about apprenticeship or if it's going to be a good fit for you and you just want to try it out, you can actually sign on as a partner through the NYCHA program and HCAP, and we take care of all that for you. So the employer just has to worry about the OJT, and the education partner just has to worry about the education. Right now, we are actually working with, like I said, about 6 states so far. Personally, I know Madeline's working with others where we are not only the HRSA recipients, but other types of organizations that are wanting to participate in the apprenticeship, but again, they don't have the capacity or the expertise, or they're a little intimidated by the process. They are actually just kind of signing on with us, and we are helping them in that way. We also do have some of those partners that have elected that they do want to be their own sponsor. So it's not an either or situation. If you want our assistance, we're able to help you go through that process and become your own sponsor. But for those that, like I've said, are a little intimidated or not quite sure if they want to do it yet, we decided to go through and register a program just to do that for them. So there is my contact information there. That is actually all I have for now. I believe there's going to be some Q&A at the end. So if we want to take a pause here, and I'll be happy to answer questions here in a few minutes when the time comes.
Thanks, Jake. There's just one question that I want to answer now from the chat box. And that was in the first half of your presentation when you were talking about the return on investment from CHW programs. Can you comment if CHWs were employees or how they were brought into those interventions?
Yeah, I believe they were employees. I know in at least a couple of the cases they were. I'm not as familiar with the third. That, like I said, that was something that Madeline was working with. But my understanding is that all of these programs, they were actually employees. They might have been paid through some kind of grant funding. I know that's very typical for the occupation, but I do believe that they were employees of the organization.
Thanks. Yeah, I'll just recall briefly back to our last webinar where our speakers are really calling for sustainably employing CHWs, even when the funding is not really sustainable. You know, you blend different grant programs together in order to offer a CHW permanent role that's not going to end just because one funded program ended. So thank you. All right, I'll now turn it over to Teresa. It looks like you are getting it set up,
Excuse
so
me,
thank
can y'all
you.
hear me?
Yes, we can hear you.
Okay, I'm having a lot of technical difficulties over
Oh,
here. Um, I started off on my phone and then it just put you guys off. But now I'm on my laptop because I go to HCC
oh,
and
Lori,
we
I'm
just
sorry. I thought that was maybe Teresa asking. I'm gonna chat you privately.
thank you so much. I appreciate it.
Uh-huh. All right,
But
Dr.
what I wanted to ask you guys was, okay, we graduated in 2022, but you know, it's really hard for us. It's a lot of us that are still, we're licensed to be community health workers. Um, we had a grant. That grant ran out.
Mm-hmm.
We were only getting maybe 2 hours a day or 2 hours a week.
Mm-hmm.
We can't live off of that, but we can't get hired as community health workers because it's like they don't know anything about community health workers,
Mm-hmm.
or they feel that we're not, I guess, maybe competent enough to do the job that we're applying for when half of us that are community health workers have been doing this for 10 plus years. I've been doing it for 30.
Well, Ms.
So
Milam, and thank you. This is exactly why we're holding this series. And honestly, the reason I got into public health 15 years ago was because of my love for community health workers. And it breaks my heart that there are so many community health workers doing the work and then aren't able to find employment. And so that is exactly why we are doing this series. And bringing on experts who can really be champions for employing CHWs, proving that it's financially sustainable to employ CHWs and talk about the great work that they do and their effects on health outcomes and the bottom line, which is sometimes that's what employers care about. And so I hope if you're an employer on here that you just took what Lori said to heart, and that if you're not an employer and you're a CHW and you're in this position or you're a CHW champion, that after I send out the recording, you send this recording to a potential CHW employer, or an employer who doesn't yet understand what CHWs are, and they might go under a different title, a community representative, a peer navigator, a patient navigator. And so that together we can really change the employment outcome for CHWs. You know, I was just reading that by 2029, the number of community health workers in the workforce is expected to grow by 17%. Right now, there's an estimated 60,000. And that was actually a mid-COVID number. And so, you know, hopefully we're already above that 60,000. And so if you are on a CHW, if you're a CHW here, thank you for your work. Stick with it. I do really think we're at this exciting time that this workforce is growing. Thank you, Lori.
you're welcome. You're welcome.
All right, Teresa.
Hello, everyone. You heard my introduction, and so I just wanted to talk a little bit briefly about the presentation prior to mine. And at UNTHSC's State Certified Community Health Worker Center, it's interesting to know that we've been doing all of these different models. We actually partner with the HRSA grant recipient at UNT Health at UNT Denton that is, you know, doing apprenticeships and different things. So we're connecting them with community-based organizations to help be that conduit to those apprenticeships. We have had MPH students reach out to us to use the community health worker certification course as their practice experience for their undergrad public health degree. So we try to think outside the box for everything so that we can provide opportunities for everyone that approaches us about how can we make this work for you, but at the same time extend the workforce. We have a couple of community health worker instructors who graduated from our center who, we teach for free because of different funding that I've been able to keep sustained. And so they want to give back and are offering to teach in their rural communities for free by affiliating with our center and then utilizing our curriculum to do so. Of course, we have an MOU with them, but we really try to be as open-minded and try to fulfill the needs so that everyone can be successful in helping to build this workforce. So I just wanted to share that with you. So today I'm going to tell you about a couple of success stories we've had besides the ones I just mentioned, but some that we've actually had measured our outcomes. So I'm going to give you a tale of two community health workers. So the first one I'm going to talk about is how community health workers can be partners in research. And this is based on a case scenario that we experienced out in Mount Pleasant, Texas during the pandemic, where they had the highest rate of COVID-19 during the pandemic. And there were distinctive factors that made this demographic more susceptible to contracting the virus. And experiencing perpetuating circumstances. So knowing that Mount Pleasant is a rural town, they were a hotspot for cases, especially in the Hispanic community, who were predominantly employed by local agriculture and manufacturing industries, which of course, as we know, requires working in close quarters. And so we were asked by the administration of the hospital, which we know in the health literacy world, that you have to have leadership buy-in to be successful when you're doing health literacy interventions. But knowing that they approached us gave us a lot of power to know that we would be able to make a change. So we examined the potential barriers to proper precautions and action steps to lessen COVID-19 spread. And so what was the first thing I did? Hire a community health worker. Now, interestingly, to speak back to the presentation before, she was not certified when I hired her. She was mentored by us while she was performing these duties. And then also we paid for her to get her certification while she was working with us as well. So what we know is that in June of 2021, they were the per capita cases in Titus County, where Mount Pleasant is, was 815 cases per 100,000 people, which is far above the state average of 58 cases. And the vaccination rate lagged behind the state's rate of vaccination. So what we did, as I mentioned, was we explored these contributing factors leading to fractured communication between Titus Regional Medical Center and the Hispanic community of Mount Pleasant. So Brenda, who we hired, helped us because obviously she grew up in Mount Pleasant. She had gone to high school there, junior college. Her parents still worked in those industries that were in the hot spots. And so we know she had the trust of that community and was able to connect us with the churches and the workplaces to be able to do focus groups. And you all know, of course, the background about why community health workers are effective, so I'm not going to go into that. But having her be able to connect us to these focus groups was instrumental in being able to solve this problem. So we worked with her to create a semi-structured focus group script, recruited 30 people from the community, conducted 4 focus groups, 3 in person were in Spanish and 1 virtual was in English, transcribed, of course, just using typical research methods, the focus groups, and applied thematic analysis to identify themes, generating a report for TRMC administrators, Titus Regional Medical Center. So what we found was that many times people were sent away from the medical center because they assumed that they couldn't pay. So there was inadequate billing explanation, especially when there were language barriers, rushed and impersonal service, and then they lacked cultural competency. And in fact, they had sent me a news story that was done during the pandemic about Titus Regional Medical Center. And the first thing that I noticed as I was watching this news story, because they were panning through the hospital, was that all of the employees were white and there weren't any Hispanic or bilingual employees at the hospital. So as we worked with the community to find out what would make them feel more trust and be more open to Titus Regional Medical Center, and at the same time get the information they need, it was that they needed community engagement, and clearly Spanish translated materials and instructions about what to do. But they also wanted to create a patient advisory panel and be integrated into the workings of the hospital on an ongoing basis, which was surprising to me to know that they were that passionate about wanting to partner with the hospital. Excuse me. So we identified these gaps in community relations and culturally and linguistically congruent communication, because basically TRMC was putting all of the health information for COVID-19 on the website in English. And so we knew that none of the community had, or the 60% Hispanic community, few of them had internet access, and most of them were not bilingual. So we helped the hospital to see that this was a problem, and we helped them to make sure that they were providing Spanish information and how they were providing it. So how the Hispanic community wanted it was, you know, flyers in the windows of local stores, things mailed to their house, working through the churches and through the workplaces, et cetera, in order to get the information to them. And so Titus Regional Medical Center ended up opening, a bilingual clinic and bringing in a bilingual provider from outside of the community to come in and do this work to make it more health literate and more culturally competent. So that was a best practice scenario of outcomes, because again, if you don't have leadership buy-in, you might not get the same outcome. So the second case is extending the clinical workforce in the community. And this was actually done through my university through a pilot program that I started with our older adult house calls program. So we know that research supports the fact that putting a community health worker into primary care, especially for vulnerable older adults, can be successful in helping to extend the workforce, especially once we got into the bundled payment era. And so we, thought to ourselves, this would be a good idea to help us expand the work of our one nurse practitioner that's out there trying to see these vulnerable older adults, when we know that about 5% of our older adult population that are in our house calls program live in these zip codes that have a very, well, not very low, but a low life expectancy, but that have been titled as underserved or more vulnerable within Tarrant County. And so we wanted to be able to expand that service, knowing that we were only touching the tip of the iceberg in the services we were able to provide. So we launched a CHW pilot to support the house calls program. And as of this February, there were 226 active patients in our house calls program, up from 56 patients in August of the previous year. And some of the things that our community health worker does is she helps to enroll our community members in a chronic care management program so that they get ongoing, regular healthcare services that they might not have gotten otherwise, which then, of course, helps them stay healthy and well in their own homes, use emergency services less hospitalizations, et cetera. More house calls where they're getting this care at home, and which prevents these poor outcomes, as I just mentioned. Medication review. So she'll go over their medicines with them via Zoom or in person, and make sure that there's, they're taking the right medications that are on their medication list, et cetera. And then also making sure that they receive the vaccines that they may be missing, or even, specific vaccines that are being targeted by the public health community. So outcomes, she's done 79 total. This is since August of last year. Medication reviews. She's increased chronic care management enrollment 36.6%, an 8.9% increase in shingles vaccines, 56 total house calls performed by her herself, and 360 phone calls where she will call to follow up on care instructions, or what the nurse practitioner might ask her to say, this person's having difficulty with X, Y, or Z, and then the community health worker will call and follow up to ensure that that does not become a larger problem, resulting in a poor outcome. So that is the two stories I wanted to share today. I know we're a past time, so I'm going to leave it to our hosts to decide what we do about questions.
Yeah, no, this is great, and I really appreciate all of the stories and the evidence that's come to bear. And I know that people need to run. I want to encourage those that are able and willing to stick around with us for a few more minutes to answer questions. I know there was one question from Christian in the chat asking about the lack of live language access that you're addressing. What are some of the strategies, maybe, Teresa, Dr. Wagner, that you've seen employed to kind of help make sure that we're addressing people's linguistic needs, whether it's in a clinical setting or public health setting?
Yeah, there's a lot of different strategies that can be used. Again, of course, probably best case scenario is employing people who have multilingual skills, but language lines, if that's not possible, there are some that you can use on an intermittent basis, so you're not having to pay for it full time, but you can use it as needed. And there's a lot. I don't have them top of mind right now. That's a whole nother presentation, but I do have a list of some of those things that can be employed. But again, it's really important to have those resources available, because as we know, one, it's not legal to grab someone's child and say, can you please translate this for us? But it's also not best case scenario to grab a random employee who is not a certified person either. So I'd be happy to share those later. If I can share them with you, Jason, if you want to send them out.
Yeah, that'd be great. And I know from our experience here in San Antonio, we have a student faculty collaborative clinic serving the resettled refugee population here. And part of the approach that recently has been adopted is they've hired their first community health worker who speaks, because we have a very large Middle Eastern Afghani population that's moved in. They speak Arabic and as well as Pashto, so at least some of the major languages, but it doesn't address all the need, right? And so I think it's understanding the needs of your community, and as you mentioned, Teresa, hiring the right people, not just as language navigators, but as that cultural navigator as well.
Right.
So, and then there was a follow-up to that about curious if the CHW get a lot of pushback. Do you find with like focusing on vaccinations, are you getting community resistant to the idea, addressing the kind of vaccine hesitancy and concern that folks have? Have you observed that in the work, Teresa?
Well, as you saw, that her increase of vaccines was a much smaller number. So yes, again, you always are countering people's innate beliefs. It could be religious beliefs. It could be, a wide variety of things. But of course, we all know that community health workers know how to navigate that conversation without alienating that person. So perhaps it's not a first-time conversation, but maybe it's a second, third, fourth, fifth, sixth, seventh conversation. So, just being persistent, but also keeping that community health worker demeanor.
Yeah. I appreciate that. And I'm going to take the liberty of asking one question for Jake with the kind of on-the-job training piece. What have you found in terms of the strongest cases that you can make for employers to bring on apprenticeships into CHW positions? Is there like a nugget that you can offer to us that we can take to other employers, to the comments that have been going on about how do we ensure that people are getting the jobs that they're now qualified to do, or get into a job so that they can get qualified?
Yeah, sure. I think as far as that goes, you kind of mentioned at the top, it sounds like Texas is now in the process of trying to make some of those services billable. We have found that in the states where that is already the case, it's a lot more of an easy sell. And then from there, even like doing some kind of apprenticeship isn't that difficult because they're already hiring the people and training them, as I mentioned. I really think the couple examples that I talked to at the beginning, those are really the ones. I mean, when you're talking about trying to sell a community health worker role to a leadership of an organization, a lot of times the ones that I personally interacted with, it's just that financial aspect of it. They just are like, we don't have it in our budget, we can't do it. And so just really pointing out like, well, we understand that, but just have a little bit of foresight here. And if you just kind of put some of this upfront investment in, then you can see it's got, such a return on investment, and you're going to be saving, ER utilization and things like that. That'll help you do it. So I think like just, as far as specific example, those are the ones that kind of come to mind, especially that Fuse program that Madeline was working with, where those two individuals, I mean, even in 6 months, they saved 158,000. I mean, was, considering fringe and things like that, that's probably, basically paying for itself.
Yeah,
No,
I've actually
Go ahead,
had
James. Sorry.
had those same conversations with healthcare entities when, they're looking at the front end of, I have to pay for my provider to stay in the room, or whatever, to make sure the person understands, or but you have to direct them to the cost savings at the end versus what's gonna be saved up, or what you're spending up front. As you said, it probably pays for itself, if not more.
And I think part of it also is just continuing, as Shan mentioned at the end of her comments, continuing to build that evidence base, right? I think so many of us working in this space, whether it's locally or internationally, like have seen the impact. And it's only in the last, like I'd say 10 years, that we're really starting to build that evidence base around it that people can grab onto. And so we've got to combine the amazing stories that we're hearing in meetings like today with the data that kind of shows both that economic impact as well as the impact on those indicators that we find so important in health and public health.
Yeah, one thing we've done, just real quick, sorry,
Yep.
out in the rural areas is try to be a conduit of those out in the communities that we're training and the closest healthcare system, or even linking them to community-based organizations such as libraries, et cetera, that can help to champion them getting hired within their communities at some point and at some level, just to get that conversation and that example started so that people can understand what a beneficial force they are.
Yeah, and to that point, we've also found that through our program that those internships and experiential learning opportunities are vital to expanding people's understanding. And if I've shared this story before, I apologize, but one of our partners placed one of their CHWs at a public library, and that public library turned around and hired that CHW to be part of their team. Now that's super exciting to me. That's the space where health happens. So Shan, I know there was a long question. I was hoping you could help summarize for us, and then we can start to wrap up.
Yeah, so Donna Murphy, who is a CHW and neurologist, which as an aside, I would like to say that I personally love when other healthcare workers get trained as a CHW, or CHW decides to get trained as a different healthcare worker. I think it's a great way to build, I don't know what the evidence, build team-based care. And when I got trained as a CHW, I learned about all this like theory of practice, and I think it's great. I think everyone should be trained as a CHW, and that together we will all make our healthcare system more equitable and inviting. Okay, I will get off my soapbox. The question is, this has been inspiring. what can employers, and Donna is also an employer, and a physician, what can employers or leaders and physicians of the healthcare system do to advocate for CHW employment through, for example, op-eds, position papers, testimonials? So maybe Teresa, I see you shaking your head, so I'll let you start.
I would say all of the above. I've done a lot of advocacy for health literacy in our state, and I've done everything possible. So yes, definitely trying in every way possible to do so, and really showing those outcomes and how they can enhance not only public health, but help reduce healthcare costs and improve quality of care.
Jake, anything you want to add to that?
You know, I think she summed it up perfectly, but I do want to also say, kind of when Shan started talking about getting trained as a community health worker and other professionals, that also you know, is a way that I have seen organizations introduce that role into it. So they'll take individuals that are maybe front desk who speak a certain language, you know, and kind of train them up as community health workers. And then because they're already employed and sort of doing these dual roles, it's not the most ideal, obviously, for just the CHW work, but it is a way to sort of ingrain that into the organization and be able to sort of slowly move towards that without necessarily having to create a whole new position in the budget or things like that. So I would say, you know, encourage some of those organizations to really just explore it in that way. And then when they start to see the actual return on investment coming back to them and it doesn't become just theoretical, you know, they might be willing to sort of take that next step.
And the only piece that I would just add to it, circling back to the very beginning of this webinar, is taking advantage of the opportunities that sit in front of us with the new state legislation to pay and reimburse for CHWs and doulas within the maternal health space by really making sure that we get that right. So bringing our voice to bear to make sure that the reimbursement costs are appropriate, that the roles and responsibilities align with the roles of community health workers, and making sure that as we're doing the work, we're collecting the right data to show the impact, so then we can ideally make the argument collectively about why the expansion for CHWs across the board, not just in maternal health, needs to be part of the larger conversation. So I want to give Dr. Wagner and Jake one last chance. You got 30 seconds to a minute to make one last statement if you would like to.
I think I'm good. I just want to applaud everyone for being here and being such a strong supporter of community health workers. We all know what a great asset they are to the health workforce.
Yeah, I think I'm good as well. Just, you know, if you do have any interest in further exploring the registered apprenticeship model, you have my contact information. Please feel free to reach out. And then I would also say on behalf of Madeline, I know she was disappointed she couldn't make it. So she's happy to provide some additional information on those case studies that I shared as well.
Well, I want to thank you both for sharing your time, knowledge, and expertise. We do have a brief kind of post survey, right, Shan? Did I get this right, or is this not meant to be up here?
We can try it.
Right.
I will look for new responses.
No, it's fine. I think we can put it into the chat. We can send it out. I just want to thank you all for spending time with us today on your Valentine's Day. Dr. Wagner, is always so wonderful to hear your stories and experience. Jake, we really appreciate you bringing your expertise with apprenticeships. And for those that are looking to help expand the workforce, we've got opportunities right now to train people at little to no cost. We can put them through on-the-job training programs and help us get the word out. If you know of an employer that can be brought to this conversation, I'm happy to go and talk with anybody. So so thank you all. Really appreciate it, and wish you all the happiest of Valentine's Day, and look forward to seeing you.
Can I ask you a question?
Session. Oh yes, please.
Y'all are with U of H, right?